to CVCT 2012 in Paris. I'm Tariq, I'm Duke Cardiology Fellow. I'm honored to have with me Dr. JANUZZI, Associate Professor of Medicine, Harvard Medical School, and Director of the CCU at Mass General Hospital. Dr. JANUZZI, it's an honor to be here with you. Dr. JANUZZI is one of the world experts on cardiovascular biomarker studies, and something that I'm very interested in. So Dr. JANUZZI, you just shared this great session and kind of where to move forward with biomarker studies, and one of the first slides you showed was this diagram that shows the number of biomarker studies that have been published recently, and there's a lot of them.
Yeah.
So how do you think that as a community we should be integrating all this onslaught of data and making sense of it and then moving forward from here?
Sure. Well, it's really great to be here, and thanks for interviewing me and bringing this topic up, because I think it's a very important and relevant area for not only clinical trialists but also clinicians taking care of patients to better understand. As I said during the session, there was a time when biomarker studies were nothing more than a curiosity attached as a sub-study onto a large trial. Over the last decade to 2 decades, it actually has become a science unto itself. You can now hear that people identify themselves as being a biomarker researcher, right? So the field has gained credibility and viability, particularly because of the natriuretic peptides and troponins really favorably affecting our clinical care. But there are a lot of challenges at this point. I mean, I think one of the more relevant issues, both from a clinical trial perspective and a clinical perspective, is the fact that it is very easy to do a biomarker study, but it's very difficult to do a biomarker study well, and it's very difficult in particular to do a biomarker study that carries clinical relevance, that can actually generate actionable information for us at the bedside. And that's really the relevant challenge, I think, moving forwards.
That's great. Dr. JANUZZI, this came up during the discussion a lot about statistical methods to analyze this data. Do you feel that we should be using the methods that we have right now, or the reclassification index and C-statistic, or should we be developing newer methods to be able to figure out what this data means?
I think that what we need more than anything else right now is a consensus about what are the basic expectations, and when a biomarker is examined in a clinical trial utilizing the established framework, how do we interpret the results? So, for example, if we have a basic expectation that every marker in a prognostic study is evaluated with Cox proportional hazards modeling, C-statistic change, and reclassification improvement, the question I would ask is, how do we interpret a marker that achieves 2 out of the 3? Or only 1 out of the 3? Is the first marker better than the second? And how we grade the quality of evidence, much like we do with guidelines, may be one way to approach the huge amount of heterogeneity that we see in terms of the studies that are submitted to journals, and also, I would say, as a clinician, how we interpret the results. Because clinically speaking, if I see that a marker is extraordinarily powerful in a Cox model and moves the C-statistic significantly and reclassifies risk, clinically I'd be much more likely to use that marker on a day-to-day basis than one that may not perform very well.
So JANUZZI, my last question for you is that there's a lot of markers out there, but there's very few markers that have kind of gone through every step of the way to move forward and go through a randomized control trial. And one of them is high sensitivity CRP. So it went through the association studies, and then some would argue a randomized control trial based on a therapeutic intervention. Do you think that sets the paradigm for all biomarkers, or should we be looking at it in a different way? Because that took a long time, and there's a lot of biomarkers to test.
So the biggest problem with where we've been and where we're going is the fact that we lack well-defined phenotypes for what these markers are telling us. Said another way, it's often very difficult to understand what a marker is telling us. CRP is a good example. It identifies risk, but the real question is, what is that risk from? We argue that it may be a future risk of myocardial infarction. We argue that it may be related to inflammation in the vessels versus metabolic really truly what CRP is reflecting. And so in order to well design an intervention study that targets that biology has been challenging. Now, the natriuretic peptides are more well defined, I would argue, with respect to the pathophysiology that causes their release, and hence we've been able to move forwards with some biomarker guided therapy studies that target the biology leading to natriuretic peptide release. Moving into the future, newer markers like ST2, galectin-3. Again, the relevant challenge is understanding why they rise, what we should do when they rise, and how will the patient do if we make a change targeting those elevated values. And unless we achieve all three, it may be very difficult to get over that bar to produce data that make these markers worthwhile to use on a clinical level.
Well, thank you so much for your perspective, Dr.
Thank you.
It was a great honor to talk to you, and I learned a lot.
Thank
you very much.
Yeah, appreciate it.